Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hello, this is Dr. Nick Biasotto. I'm the host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. Today our subject is hyperbaric oxygen, an underutilized medical modality. And our guests today are Dr. Zack Gaskill and Nurse Lesa Prichard. But before I get into their bios, I'd like to say that if anybody has piqued their interest with this interview, there's an excellent book on hyperbaric medicine called Hyperbaric Medicine Practice by Eric Kindwell and Harry Wayland. You may want to look that up if you so desire to learn a little bit more about this that we can discuss here today. Our first guest I'm going to introduce is Dr. Zack Gaskill. Dr. Zack Gaskill and I go way back. I treated his whole family. For many, many years, and I've treated him as a youngin'. I think in your teens you started coming to me, correct?
Even younger than that, too.
Okay, all right. Well, he he was interested in becoming a physician, so he wanted to go to medical school, and he did. But he then did a preceptorship with me, in which he spent a month in my office, and we went through our patients that came in through the office with their complaints, etc. And I was, at that time, the medical director of ChristianaCare's Wound Care and Hyperbaric Oxygen Center up in northern Wilmington. And I would take Zack up there every Tuesday and Thursday when I would be working in the center. And little did I know that he fell in love with hyperbaric medicine and wound care. And that's where he went in his further training. So let's go further with Dr. Gaskill. He's a graduate of Lake Erie College of Osteopathic Medicine. He completed his residency at Philadelphia College of Osteopathic Medicine and then completed his fellowship at the University of Penn. His fellowship was in undersea and hyperbaric medicine. He loved it so much. He presently is assistant director of the University of Penn's Multiplace Hyperbaric Chamber and Outpatient Wound Care Center. Lesa Prichard. I also have some long data about Lesa Prichard. We had worked together very well at the Wound Care Center up at ChristianaCare's branch in northern Wilmington. And Lesa received her liberal arts degree from Westchester University. She received her RN degree from Brandywine Hospital School of Nursing and Immaculata College. She then received her Bachelor of Science in Nursing from Immaculata University, and then later went on to do a master's degree in nursing from the Wilmington University. Presently, she is the nurse director and manager of the Wound Care Center, Hyperbaric Center at ChristianaCare's Wound Care and Hyperbaric Center in northern Wilmington. And Lesa and I worked together very well at those times. We had very good results with our patients. Healing achievement was way up. Hyperbaric was underutilized, and that's why we want to talk about that today. Lesa, I read your master's thesis, which was a good read, I have to say. It was very good. I'd give you an A.
Thank you.
And in it you mentioned that, of all the indications for hyperbaric oxygen, only about 7%, roughly, are being used for those indications when there are many other patients that can be treated at your center. 93% aren't being utilized when they could very well be. Why is that?
I honestly think it's lack of education and awareness.
Okay.
Hyperbarics has been around, I think, first pressurized room was in 1690. And
even before oxygen was invented, correct? Right.
And it came back into play in the 1800s and started being used for medical therapies.
Okay.
It's something I know going through all my education. Never once did I know what hyperbaric oxygen was until I actually got into the workforce. Mm-hmm. And I don't know between you and Zack if it's something that was taught in medical school. I know Zack had it rounding with Dr. Biasotto.
That was it.
But prior to that, throughout the schooling, formal schooling, and other rotations, I just don't think there's an awareness.
Well, let's get it made more aware through this podcast. What do you think? Huh? Okay.
Sounds like a plan.
All right, Zack, tell me, what is hyperbaric oxygen?
So the concept kind of stems, as the name implies, kind of twofold. So the first is any physiologic effect can be derived from pressurized gas. The one that is most well studied clinically is oxygen, and that's where a lot of the clinical benefits that we look at through hyperbaric oxygen therapy are the ones that are then going on to kind of form the labeled indications.
Okay.
The majority of this is delivery and patient selection. So the delivery is where anything over 1.4 ATA in a hard-sided chamber constitutes hyperbaric oxygen therapy.
That's atmospheric pressure.
Yes, so
okay.
ATA being atmosphere is absolute, including the atmosphere with which we already exist under.
Which is 1 atmosphere.
Right.
Go ahead.
So that's already kind of enough to derive clinical benefit. The gas itself and the setting is what then is the question and task is, where do we go with it? What effect are we trying to achieve? Okay. So what we wind up looking at is, in the right patient, the right dose, and the right duration of therapy, trying to elicit that end target effect. But ultimately, it winds up being the delivery of pressurized oxygen in a hard-sided chamber for a set period of time and treatments.
Got it. Now, without going into the physics of Boyle's law, Dalton's law, and Charles Henry's law, in essence, what hyperbaric oxygen, when you're breathing 100% oxygen in an increased atmospheric pressure chamber, what happens to the gas is, in essence, it solubilizes in the plasma. True? Okay, so we have an individual whose hemoglobin, which we all know what that is, carries oxygen to our tissues. And the oxygen is delivered through the arterial system, and it returns to the heart and the venous system. In the arterial system, hemoglobin is saturated with oxygen. In the venous system, it is not. It's desaturated because it gave its oxygen to the tissues, and then it comes back to the heart deoxygenated. When you have this oxygen under pressure being breathed, it's soluble in the plasma, so that even the venous return to the heart is loaded with oxygen carried in the plasma, correct?
So right, you're going to wind up maximizing a lot of those inefficiencies where there's a physiologic rate-limiting step, whether it's the hemoglobin carrying capacity, whether it's the vasculature to an area, or just what the diffusion gradient would be in the tissue. You're allowed to kind of round up for a lot of those shortcomings that either the person has pathologically or that the area may have inherently anatomically. But yeah, bypassing and being able to diffuse into plasma is a huge, both acute and long-term component of where the therapy aims to go to.
Thank you. Okay, now, what are the physiologic benefits of hyperbaric oxygen? I know it increases fibroblast proliferation, hyperoxygenates the tissues, increases blood transport of oxygen to the tissues. It increases phagocytosis, getting rid of destructive tissue in the body, and it has antibacterial effects, especially on anaerobes. Is there anything else you want to add to that?
So we classically train some of the residents, fellows, and some of the students to kind of think about it in two capacities, because sometimes what happens with a lot of the indications, which can seem very, very different from each other, is that it's hard to link how is this a commonality between very different patient populations and different etiologies. And that's something where, exactly like you said, there's a lot of cell biology that goes into it. There's a lot of things where the biomechanics are really important into what it's doing as far as immune modulation, anti-inflammatory components, vasogenic components. All of these things play a role, and I think that the big buckets that we tell people to put them into is either, are you impacting or having an effect on the ischemia or the vasogenic side of things, or are you working under sort of more the auspices of the anti-inflammatory role? The beauty of the therapy is that there are instances where you get to have both, and you don't have to pick either or, and there are certainly patients who need both.
I would like to water down a little bit of your terminology for the non-physician, non-nursing people, so they would understand. For example, ischemia, the lack of tissue oxygen, okay? That tissue is suffering from a lack of oxygen, and that's called ischemia. All right, Lesa, describe a monochamber. Here's the difference between Penn and the campus at Christiana. At Christiana, we have 3 mono chambers. Mono meaning one person per chamber. At the University of Penn, we have a multiplace chamber where you can actually treat under the same conditions multiple people with multiple different problems. Describe the chamber that exists at the one mono chamber that exists at just one of them at Christiana's Wound Care Center.
Sure. It actually reminds me of the old MRI machines. Okay. So it's cylindrical in shape. Patient goes in, they're lying down on a stretcher. Most of the chambers nowadays have clear plexiglass around them. Mm-hmm. So you actually are sealed in at both ends. And I'm sure we'll get to this, restricted items in the chamber, mm-hmm. but most of the chambers have some sort of audiovisual, TV, movies outside the chamber mm-hmm. on top, so you can hear it's piped into the chamber. A lot of the patients go in, they will either fall asleep, they will watch their favorite movie on TV, watch their favorite game show. Mm-hmm. Treatment lasts for that about 90 to 120 minutes.
Got it. So the clear plexiglass takes away the claustrophobic effect. Yes. And the teeth, you can now. I'm also going to bring this in now because you want to make sure that you don't cause any sparks in that chamber, because 100% oxygen and even static electricity can cause a big boom, meaning that we'd all become astronauts if we were working in that area.
Very true.
So tell me how a patient is dressed, how they go in, and what that is all about.
Yes, so we have designated linens for the chamber, so usually 100% cotton. Mm-hmm. Patients go in 100% cotton scrubs. There's an quite extensive list of what they can and cannot do prior to going in. They are not allowed to bring anything like a cell phone, watches, anything metal at all.
Even a book, you can't. Just in case there's static electricity, right?
Correct. Yes. Prior to them, on their person themselves, no perfume, no hairspray, no nail polish.
Anything that potentially could cause a static
even with
or a
baby
spark.
powder. Correct.
Understand. Now, tell me a little bit, Zach, about the multiplace chambers and why they have a little bit extra benefit over the mono chamber. Can you discuss that?
So the multiplace is one where each one is relatively unique to what the initial ask was for the institution. So monoplace chambers are something where, reassuringly, if it's something that somebody were to look at online, they may be more pleasantly surprised to see something very similar to that when they show up for their consult. Mm-hmm. Multiplace are kind of more one-offs. But a multiplace, what I would describe it as, is essentially, if you think about it kind of like an airplane that's divided into sections. So we have rooms full of multiple seats that can fit groups of people, and they are partitioned off so that if I need to treat certain groups at different doses or for different durations, I have the ability to close doors and separate out the pressure difference between the two. Mm-hmm. There's a lot of flexibility that happens, and one of the flexible kind of add-ons clinically is that in a monoplace chamber where there are restrictions because you're compressing on 100% oxygen, in a multiplace chamber you are compressing on air and delivering through a mask 100% oxygen. So the environment that I get to work in, yes, it's compressed air. Yes, there are still things where it's similar to diving, where physiologically you have to sort of contend to. But the flexibility electronically, equipment-wise, and just the ability space-wise to be able to lay hands on a patient, perform procedures, and to remediate things that may happen during more emergent treatments are all things that the multiplace kind of adds to you. And it's clinically dosed exactly the same next to each other. The same dose delivered in one to the other is a lateral move. Mm-hmm. But as you start asking for increased capabilities, increased flexibility, and the ability to kind of handle an emergency while you already may be treating one, that's where it really becomes a really nice luxury.
It's a good, the multiplace chamber makes it more prone for you to treat some of the conditions we can't in a monoplace, because you can have an attending standing in that center, attending to a critically ill patient, say, we'll talk about this later, but necrotizing fasciitis. You can have them, they're usually shocky, they've been in ICU, they've had surgery. I mean, you can attend to them directly in a multiplace chamber, when in a mono chamber, it's a little more difficult. Okay. Do you ever have problems with claustrophobia in your center, in your multiplace?
To a lesser extent. We certainly see people who need therapy but just cannot tolerate monoplaces. What I will tell you is, interestingly enough, some people find monos with the acrylic being clear actually easier on them, because even though, and that's when you get into the semantics of, we see more people who have issues that get tripped up with confinement anxiety versus claustrophobia. So the concept of seeing this giant multi-inch thick steel door, like bank vault, close behind them, it doesn't matter if the room is this size and all of a sudden that vault door closes, they don't like that sensation. So that's something where I see much more of that than I do the claustrophobia side of things. But having said that, the added flexibility is that, as would be appropriate, I can be a little bit more aggressive with anxiolytics, because I have the ability to kind of monitor, run telemetry, run those things in there, so that that in and of itself isn't a hard stop. But yeah, interestingly, more, I would say, confinement than claustrophobia. Okay.
I trained in a multiplace chamber in Texas. It reminded me of a submarine, basically. I mean, it felt like I walked into a submarine. You know, it's confining to a degree, and there's big walls around it, and you have limited area of space. So it's similar to that. All right, let's go on and talk about the approved conditions of hyperbaric oxygen. We'll start with decompression illness, because that was basically what it was first used for. I mean, basically undersea divers that get in a bad situation have to rise quickly, and they can get the bends because they're... Let me explain the bends, if I could. The bends is a condition in which divers are breathing air. Not 100% oxygen, they're breathing air. Air is mostly nitrogen and a certain percentage of oxygen. That's what we're breathing right now. But when I dive, and I have brought back that principle of the gas, that the gas is dissolved in the plasma, it's almost liquefied in the plasma. So if I'm down at 33 feet, which is 2 atmospheres, 66 is 3, wherever I'm at down, and an emergency situation occurs and I have to get to the surface quickly. If I get to the surface too quickly, the nitrogen in my body has not had a time to change from a liquid, and it's changed automatic. It's not dissipated slowly. It's changed automatically on the surface to nitrogen bubbles, which go into all of our tissues, our joints, air spaces, producing the condition which is very painful and life-threatening, the bends. In decompression illness, talk to me a little bit about that.
So a lot of what you'll see is labeled decompression injury, decompression illness, and then of which DCS, or decompression syndrome, or decompression sickness, is the bends. A lot of that gets into exactly what you mentioned, is that different tissues saturate at different speeds. And that can be good in the sense that you may on-gas or take tissue or take gas into a tissue slower. But that speed, right now, there's some interesting things that I'm sure that would kind of derail us. But there are things that are we are the rate limiting step in all of that. We are the weak point physiologically, and they try and keep working around that. But interestingly, one of the things that comes of that is that different tissues, the speed is not really adjustable. So if it's slow to take on, that's good, but that means that you still have to pay that debt at some point. So if you rise too quickly, the air gas embolism risk is going to be there regardless of depth, regardless of how long you were there. Is that if you have compressed air that you're breathing, this is not true for free divers, but if you're breathing compressed air and all of a sudden you ascend, that air is going to expand. How much is dependent on the height of the water column change. That's an ever-present risk. But if you're for too long, too deep, or any variation thereof, and that gas starts to really kind of soak that tissue, it has to come out eventually. And if you don't let it basically happen on your terms, then it will find a way to basically manifest itself. Exactly. Mm-hmm. There's really, really fun, entirely theoretic, contentious arguments that happen at conferences as to, does inflammation precede the bubble? Does bubble precede inflammation? There's right, and honestly, there's a subset of people who feel very much the same way, which is just, okay, but the end result's still where we are, and the therapy addresses both, so why? And that's something that is very interesting, but largely doesn't impact a clinical condition.
Right.
And it's something that if the tissue has to let that off and it has to get out, if you don't let it do so safely, where it manifests can be anywhere in the body, and it doesn't have to follow conventional patterns. So when we're telling people, we redo on the dive medicine side for the fellows, we redo a lot of their neuro exams. That's a big component, is that especially as you get out of practice with doing really kind of focal neuro exams, these don't have to follow any set either central upper or lower motor pattern. They can be really, really varied. So it's possible, especially when, and you see it much more than I do, especially on anyone with the occupational side involved. This is their livelihood for divers and for people. They're worried about their health, but they're also worried about their ability to kind of continue working.
Right.
And similar to pilots, there's always this kind of push-pull between, you don't want to set yourself up as, or align yourself to where you're their barrier against going back to work. Because then you don't get honest exams, you don't get honest feedback.
Gotcha.
And it's something that it makes those detailed exams really helpful, because it can really present as anything.
Okay.
And it's fascinating for the person who doesn't have to experience it.
Okay. Understandable. Okay. I often ask Lesa, when I have students, when I had students and I worked there, I used to say, in the mono chamber, breathing 100% oxygen, can you get the bends? And the answer is no, because there's no nitrogen, right? Okay. I think it's time for a break now before we continue. We've chewed on a lot of things here that you might have to think about a little bit, but we'll be back shortly.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
All right, this is Dr. Nick Biasotto, and we're back discussing hyperbaric oxygen treatment and its underutilization aspects. And we have two guests today, and that's Dr. Zack Gaskill and Lesa Prichard. So I want to continue discussing a bit about decompression illness. At your center, do you see much of that? Because you're away from the water, you're away from the divers, you generally don't see it unless you see those kind of guys, right?
So, yeah, compared to some of our colleagues who are at LSU, work in the Gulf, where there's a much larger recreational component than there would be. I would say that geographically, there's kind of two things that are at odds. One is that you're right. There's certainly a lot of people who are diving or doing off-season dive training in quarries in PA, which is a big draw. And then the other is there are some very dedicated people who, again, they will do it year-round in murky conditions in freezing water and clearly love the hobby. I am not there to do anything other than to make sure they can do it safely, and certainly not to pass judgment. But we do see less than I would say some of our colleagues where the weather and the settings are better. Where it artificially drives up the number we do see is that there's such a paucity of places that treat 24/7. We have a really large catchment area with the Coast Guard. So it winds up being that because of where we're situated and what some of the capabilities are, we wind up catching people from a much larger area than we would normally see from typical referral patterns.
Well, I was certified scuba diver, and recreationally, I used to love going down to the colors, the coral, the things like that. Wreck diving, that was really cool, and that's why we have dive charts. It says you go down for this amount of time, you're at this depth, and this is how you come up, and you come up slowly so you can avoid the decompression problem. Thank God, knock wood, I've never had that problem. All right, let's go to the next indication, carbon monoxide poisoning. Now, how does that occur? Well, generally it's accidental, hopefully it's not intentional, but it can be both. But accidental carbon monoxide poisoning that goes to the emergency room with all the classic symptoms, they're cherry red, etc., having difficulty with their breathing. They let them sit in the emergency room for hours breathing oxygen until the carbon monoxide levels lower. In a chamber, it'd be much quicker, wouldn't it? Lisa probably would, wouldn't it?
Yes.
Okay. So you take them down to theoretically, you're giving them oxygen. Now, how does carbon monoxide poisoning work? Carbon monoxide takes the place of oxygen in the hemoglobin molecule. And carbon monoxide does not supply the necessary needs of a tissue. So what you're doing in a chamber is you're bringing them much higher oxygen concentration, soluble in the liquid, making their body happy tissue-wise, and eventually the carbon monoxide blows off or dissipates. So, have you seen a lot of that at Christiana's center? Have you seen that in your center?
We see quite a bit, and seasonally, similar to the diving side of things, is that there is geographically kind of a timetable for that. This time of year, heaters are first coming on. Water heaters are going down. People are bringing things indoors. Unfortunately, like you said, there is an uptick around the holidays, one that is entirely anecdotal that I would point to as far as some people who wear it's maybe not as accidental. And there other issue that I would mention, and this is something where this has been looked at, Lynn Weaver has done an incredible amount, as have some of the other colleagues, as far as looking at carbon monoxide poisoning and looking at kind of the etiology. One of the things that we tell people our timetables for benefit are measured in hours. Having said that, we have also had EDs not refer patients because their carbon monoxide levels are already back to normal. What we typically try and tell them is that the carbon monoxide level you can wash out with normobaric oxygen, and you can do workups, and that's not an inappropriate means by which to do it for the right patient. But for a symptomatic patient, and when you're worried about delayed brain issues, delayed neurologic issues, mostly those just because of how sensitive the tissue is, one of the things that carbon monoxide does, once it causes that ischemic effect, is it sets off this cascade. And once that little ember basically sets this off, it causes this major downstream trend, which can eventually cause this, what's called lipid peroxidation, which is when you get irreversible damage that has a predilection depending on where it goes to, but preferentially areas like the brain. Mm-hmm. And that's one where it's really common in more severely impacted cases to see tissues with disproportionate oxygen demands see that. And you'll hear people call it essentially like de facto stress tests, things like that, because there's different ways that the symptoms manifest. And you're right. And we do a lot of ED outreach to kind of plant that paranoia so that it's part of the workup. But the timing and the degree of which we see cases, there's a component that you'll see year-round between car exhaust and workplace exposures, power tools, things like that, which I think are just an inevitability, even with EVs and batteries for tools and things like that. Their numbers haven't dropped. Okay. But a lot of it is going to be, like you said, accidental, and usually the other issue is it winds up impacting households. So in multi-generational homes or in different home settings, you could quickly run into going from one patient to 6 or 7 patients
in the same house.
In the same household.
Okay. All right, gas embolisms.
Yeah, so gas embolisms, to kind of piggyback off the decompression injury, have a couple different presentations. So you'll see them, unfortunately, on the iatrogenic side, you'll see them in the hospital on the clinical side, where in someone who has a lot of comorbidities, or maybe they were having either some sort of procedure, whether patient-based procedure, or they're injecting something intentionally or unintentionally into that area, or during a medical procedure, air is introduced and it moves somewhere that it shouldn't. In the decompression side and in the clinical side, again, end result is the same. Air moving through a vessel, depending on where it would be, causes both endothelial inflammation and triggers a lot of that inflammatory response, and if it's large enough, can be an occlusion unto itself. Mm-hmm. So addressing, and that's when we kind of get into where these multimodal benefits happen, addressing the inflammation while you're perfusing the area allows you to kind of mitigate both things that you're trying to kind of contend with. The issue there is that both of them are really time sensitive. So that's one where we measure that kind of window to compression time in hours.
What happens to the embolism?
So that's really fun, and it's really great to see for new fellows is that as soon as you get them to depth, typically you're going to see them dosed based on U.S. Navy tables, it's going to be to about 2.8 or 3 ATA, depending on the table you're using, but classically it's going to be in that range.
And when you say 2.8 to 3,
so yes,
you're meaning
2 right. So 2.8 ATA or 3 ATA, or in that 60 to 66 feet of seawater range. Okay. It can be really cool if you catch them within that window where you're addressing the occlusive event more than you are the inflammatory back end. You can see people have immediate symptomatic relief. And we've had people who were obtunded, had severe neurologic deficits, 5 minutes into compression, and they're asking us to change the volume on the TV. Okay. And it's really, really rewarding in that case.
Understandable.
But you can, and you'll hear it kind of colloquially called squash the bubble. And that's really what
you're doing.
What you're trying to do is just open a window into that oxygen bubble, let it diffuse out while you're compressing, and try and rebalance what that would be. And if you can play with the oxygen tension, take it to an extreme, you can alleviate that mismatch. And it's really quick.
Got it. Gas gangrene.
Gas gangrene is,
that's another treatment option.
Very much so, yeah.
Generally, you see a patient who has a wound or some injury, and you see on an x-ray that they have gas bubbles in their tissue, and you say, this is probably a gas gangrene situation. That's an anaerobic organism, isn't it?
So for Clostridia, yeah. And you'll see that with a lot of, especially where you have polymicrobial infections, depending on the patient. Okay. I'll say only for our patient population that we see, there's a large group of kind of the classic, either they're immune compromised because of diabetes or some other vascular issue, but classically that's kind of what you're thinking. Because of the volume of cancer patients that Penn sees, we see some where their immune system is artificially impacted for other reasons.
Gotcha.
But it's one where it is very much an incredibly helpful adjunct. It is not by any means the mainstay, and we work around OR times.
There are other modalities, but this is just another way to treat the condition. And that goes along with acute traumatic peripheral ischemic and crush injuries. Same thing. I mean, these individuals with crush injuries, say anterior compartment syndrome, they fillet their leg, and you gotta get good oxygen to the area so that the wound heals. But there are two other indications that I think sometimes are overlooked: an acute traumatic peripheral ischemia problem. For example, I had a patient just recently went to the ER with a white leg. I mean, there was no blood supply to the leg. I mean, the guy had some other problems causing that, but there was no supply of blood to the leg. The surgeon said, I'm thinking we're going to not be able to save this gentleman's leg. Not thinking that hyperbaric can also assist. The person was taken to the operating room, was surgerized, that they tried to bypass areas where they were blocked and things like that to allow circulation to return to the leg. Luckily, it occurred, but the healing was so slow and so long. The wounds were left open for so long to make sure that, they didn't compress the area more than it was originally. And I think that hyperbaric might have helped this situation significantly post-op, so that you can have more tissue absorption of oxygen that's being delivered in the tank.
So one of the things that I'll piggyback off of that, and it's something where I know you introduced me to it and taught me a lot about it, was there are, and I believe there are 10 studies, and I'm not going to butcher the names offhand, but there are studies that looked at measuring post-bypass patients after essentially major revascularization of macrovasculature, and using TCOMs to kind of time essentially when is their best window for subsequent amputation, subsequent revision, what that would be.
Please explain a TCOM to us, will
you,
please? No? You want him to take it? Explain a TCOM to us.
So TCOMs are essentially an external sensor that's placed similar to what you would use for ABIs, where you get a point of reference and then you get a point of interest. So you have a point of baseline on the chest, and then you find your area on the body that you're trying to look for, and it's a means by which you're measuring superficial oxygenation to an area. It's a conversion, and it uses a sensor that tries to kind of account for that.
All right. We used that quite a bit at the center, did we not? Or at least back then, to see if tissue was being perfused properly. Yeah.
Yes.
So there's this kind of arms race of modalities that are trying to replace TCOMs in kind of what future reference will be, but the amount of past data that you have on them is significant enough that it's always going to be something worth looking at. But in the study, it looked at things where, in you're trying to measure certain thresholds, a threshold, if you were to measure someone outright and it was a point of concern, where you would say this person would benefit from hyperbarics, they were getting those same levels below 30 for the sake of the conversation in people who were after bypass. Now, it was significantly better and it trends better, but the problem is that tissue is still screaming. It's still trying to make and trying to make do with what it has. That some of the studies recommended even waiting up to 4 weeks after the large bypass to kind of let things get to a point where the microvasculature and the distal vasculature was better off.
Okay.
And granted, one study, there's been many since, and I realize I can't speak well to the vascular advancements that have happened since then as far as technique and criteria there, but that's something where, again, speaking only to my experience, when we work with surgeons on the limb salvage side and we utilize that gap in between where they do a revision, they do the workup, we do the rest of the optimization while they're getting a course of therapy, and then there is this kind of staged revision down the line, outcomes tend to be better. And some of that, I think, is because you have a lot of complementary timing and complementary therapies. And I also think that there's a little bit of a bias there in the sense that there are people who can't wait, don't do as well, but their disease may be worse off to begin with, affecting that they can't wait.
Gotcha. Very good. We talked about necrotizing fasciitis or flesh-eating disorder earlier, alpha strep induced, and that hyperbaric is helpful in that setting. We talked about peripheral artery insufficiencies and that. Now, preservation of skin grafts. Skin graft is put on for whatever the reason after debridement of a deep wound, a decubitus wound, or whatever it might be. And the graft is not fully taking, it's partially taking, it's not holding up. A good treatment plan would be hyperbaric oxygen to get more oxygen to the area. If you look at electron microscopy and some of the studies that were done, you can actually see blood vessels being grown off of another blood vessel, little branches coming off, consistent with, hyperbaric oxygen's effect. VEGF, I believe, is the biggest cause of that, vascular endothelial growth factor. This is a growth factor that increases blood supply or forms blood vessels. And that has been shown on electron microscopy very well. It's very interesting. Now, other indications, refractory osteomyelitis. This we see quite a bit. Osteomyelitis is a bone infection caused by some penetrating wound generally, and the bone just is not healing under the typical medical maneuvers that we do with antibiotics, et cetera, et cetera. And some of them just take so damn long to be on an antibiotic. If you put them into the center, into a chamber, you may get more oxygenation to the area, which in turn may allow for that osteomyelitis to come and have better oxygenation, better antibiotics effects, etc. That's a good way to put it. All right. Now, This is some of the stuff I've seen and have been fascinated by, is the effect of hyperbaric oxygen on radiation-induced injuries of tissues and bone.
Yeah.
For example, we did see quite a bit at the at Riverside's campus from people who had oral cancers and had radiation treatment for the oral cancer. On the way in, that radiation treatment destroyed a hell of a lot of tissue and bone. And this is called osteoradionecrosis of the bone and the jaw particularly. And I've seen some wonderful effects from radiation-induced injuries, and including soft tissues.
Yeah.
I had a good friend of mine. He had prostate cancer. He had his prostate fully removed. Then he got radiation. 6 months, 8 months down the line, he couldn't go to the bathroom without it being filled with blood. He was bleeding quite a bit, and his hemoglobin got down to 7.
Yeah.
So he had to be transfused, etc. And I told him, I said, go to hyperbaric. He did. He received 60 treatments, and the bleeding was stopped. Why? Blood vessels were recreated, and the necrotic tissue was just sloughing itself right out. Two last indications I want to talk about. One is actinomycosis. Actinomycosis is misnamed.
Yeah.
By the name, you would think it's a fungus, but it is actually a bacteria that looks like a fungus with the little branches coming off of it. Actinomycosis causes quite a bit of tissue damage. You first have boils, which produce sinus tracts and blow up out in another area. It's quite bad. Actinomycosis is not at all happy when it gets hit with 100% oxygen under pressure.
It's something, and we'll draw an equivalency to like Mucor, and that's another one that we see quite a bit in that immune compromised patient group.
Mucor being a fungus.
Yes, and it's a similar where it causes this obliterative process where you're destroying these little kind of vessel beds, and it's trying to make itself quite comfortable while it invades and does everything it's supposed to, which it does a phenomenal job. But these both indications are married with incredibly heavy infectious disease regimen to try and abate that
years
damage.
It takes sometimes. Yes,
it is wild, and it's something where in some of these patients, I would say we see it disproportionately, at least in my experience, in like transplant patients, things where you've really done actually immune suppression to try and keep things at where they would be. That it is a scorched earth approach, and it's one that you can watch this tug of war with tissue go back and forth, and it's a very kind of scary thing to watch because it's often invading in kind of serious tissue areas where you can get either
sinus tracts.
Oh yeah.
And the treatment, as you mentioned, is year long. I mean, antibiotics, and people then suffer all the side effects of all the antibiotics. When hyperbaric oxygen can take care of it. And we had one under my when I was director over at Christiana Center, which we took care of in a matter of 60 treatments, and it was gone.
Yep.
So the patient was very happy, so was the doctor. Tell me a little bit about diabetic Wagner 3s. I know that is one indication for hyperbaric oxygen, a diabetic Wagner 3 ulcer. Tell me the difference between a 1, 2, and a 3, if you would, Lisa. You know the answer to that.
No, I do. And unfortunately, CMS meaning Medicare and Medicaid, will not approve treatment until a patient does have a Wagner 3.
Tell me it.
Wagner 3 is pretty much full thickness tissue loss with an abscess and or an osteo.
Myelitis, right?
And then that's when they will allow you to treat. Whereas if you have the Wagner 2 and you're not that deep involved yet and you don't have the abscess or the infection, yes, it is not an approved indication.
Too bad we can't get it ahead of time. But you have to tell the patient. Wait around until it gets to your bones. That's the thinking of some of our, our politicians. I don't know.
They do the same thing with osteo too, where once osteo is removed, even though they'll deem it refractory, the setting by which and all of the clinical implications that cause that problem have not been addressed by the surgery.
Right.
They've removed essentially or extubated the infected bone, which is exactly what you need to do to start the cure. And we've had them deny because they think that in and of itself is sufficient, which it's a major component of it. But the setting in which caused the chronic osteo is by no means done, and they'll still draw a weird arbitrary line for that.
And just keep monitoring that SED rate and watch it go up.
Exactly, yeah.
And they tell them, hey, it's still in the
Wait until it's a new Wagner 3 and then go from there. Yeah, yep.
Right.
Yeah.
Okay.
But on that note, too, just want to bring up with the chronic refractory osteo, there's a misnomer that you have to have a wound. You don't.
Oh, yeah.
And you don't. But
Yeah.
I think in the general medical population,
That's what
it
they're
can
told.
be closed.
That is correct. So
just
you don't have to
put that
move
out
to have
there.
that chronic osteo. Good
Yeah,
point.
the draining
Good
sinus
point.
is one that I think they lean on that terminology, and it's unfortunate that they
Right.
get paralyzed by a lot of that.
Good. All right. Next, we talked about the indications. Used to be one indication I remember that I didn't see in recent literature is retinal artery occlusion, acute. They go blind. Boom, I can't see.
Yeah.
They go to their ophthalmologist, and he says, well, you can maybe bring a little back. You maybe get some back. But if you get them right into a chamber, but the window is so short.
Really tight.
What is the tight window?
So it's something where we won't accept anybody if it's outside of 24 hours.
All right, that's the window. That's what makes it difficult.
Yeah.
If our ophthalmologist in town were more aware of this and they made the diagnosis right away, now that's provided the patient got in there within 24 hours. I would think most, if I went blind, I'd be there in a minute. But, they may not decide to do that. And if it's beyond 24 hours, then the window is gone.
Yeah.
In 24 hours, you can revascularize the area and bring a large portion of their vision back, which would be hopeful. All right, so that's still an indication, but the window's too short.
Yeah.
Okay, let's talk about side effects of hyperbaric oxygen treatment. Is it safe or isn't it safe? Barotrauma. Talk to me about barotrauma. The ears, air areas.
I think the best way to describe it is the barotrauma is if you're ascending in an airplane.
How your ears
and you're
feel.
descending, popping, having to manually, whether hold your nose, cough, learn different techniques to clear that.
Okay.
If we have patients, and we will abort the dive.
Sure.
If, depending on the severity of the pain, do the ear checks. A lot of that, and which is very nice that we can treat it very quickly with the tubes in the ears and having them see ENT.
Got it. They get the ergotomy tubes, and they come back and get their treatment, so they don't have to worry about their barotrauma.
Yeah.
Claustrophobia we sort of described. Myopia, nearsightedness. What happens to your eyeball when you're under pressure and oxygen so high? Lisa?
Oh, no, it basically changes shape.
Okay. Changes the shape of the eye. Soon you say, I only needed reading glasses. I don't need them anymore, but I can't see the tree across the street very well. Okay? So that's usually transient.
Yeah.
Some people say it's lasted a little longer than they would like, but it is usually a transient side effect, so relatively safe. Pulmonary barotrauma, similar to the ear barotrauma, where there's air spaces, in your lungs that can get compressed and possibly even induce a pneumothorax, okay? Pneumothorax meaning collapsed lung. Excuse me. Oxygen toxicity and seizures. Tell me a little bit about that.
So oxygen toxicity is essentially just it's a dose response. So the way that we kind of talk about it with people is that it's an overexcitation. The brain does an incredible amount to try and throttle the amount of oxygen that it gets. It's why we see a little bit of vasoconstriction with high oxygen concentrations, not even hyperbaric, just outright high oxygen concentrations. Your body will start to throttle down how much gets to certain areas because it wants more than it usually gets always, but not so much so that it gets overly excited. There are different rates, I would say classically, at about 33 feet of seawater or 2 atmospheres absolute. You're going to hear the number kind of conventionally said 1 in about 7,500, which splits 1 in 5,000 to 1 in 10,000. There are people who may have a predilection for a higher risk. Either they have damage or toxicity affecting their brain's kind of inherent responses. But having seizures going into it is not something that's going to increase your risk. How it progresses.
As long as you're on your adequate medication.
Yes, so you can have whatever seizure disorder they have. You can have an event at depth. where that's different in diving is that having a seizure underwater is a death sentence. Mm-hmm. Having one in a chamber is an acceptable difference, and that's one where it can be controlled differently. Another advantage of a multiplace versus a monoplace is that we have staff inside that can just take the mask off and it immediately stops in a couple seconds.
Got it. I remember, I don't know if it was while you were there or before you came, we had one seizure in our mono chamber.
Yep.
And we took the patient up.
Yep.
We didn't bring them up too quickly, but
right.
we brought them up enough.
The closed glottis,
that they didn't have other problems like
Yep.
develop. So we brought her up, and she was fine, but she was post-ictal.
Yeah.
We sent her immediately to the emergency room. They did an MRI of her brain and found she had a meningioma. And it was excited by that measure of oxygen. She had a seizure. She had this meningioma removed, and it was all gone. She came back and finished up her treatments for her diabetic wound, I believe it was. It was quite scary at the time, but to know that we actually diagnosed her brain tumor accidentally, I guess. All right. Now, we're almost at the end, but I'd like to talk a little bit about contraindications.
Yeah.
The absolute contraindications to the use of hyperbaric oxygen. Obviously, we talked about pneumothorax or collapsed lung. You put somebody in with a pneumothorax you didn't know they had. It was a small one, and you've produced a tension pneumothorax. That's the pressure in the mediastinum, in the chest, that's going to put much pressure on the organs in the chest and possibly compromise the heart and the rest of the lungs. So, absolutely not. On our COPD patients, we know they're smokers, they have COPD. We like to look at a chest x-ray to make sure that she doesn't have a pneumothorax. And if he or she has a bleb, which is a collection of air in a pocket in the lung, we would take them, but we would bring them down, as we say, dive them very slow so that they don't have a traumatic action in that area. Some chemotherapeutic agents you don't want to give it for. And antabuse, interesting enough. Antabuse, which we give to our alcoholics to keep them from drinking, it messes with SOD, which is
superoxide dismutase.
Yeah, that in turn can cause a problem.
There's a lot with the chemotherapeutic agents, and it's really one that I appreciate, and I'm very fortunate in that we have a very dedicated kind of oncology team with liquid and solid onc that have a lot of working knowledge, but there are times when we work with outside providers who I'm not as used to their workflow and vice versa, where we kind of go back through things. But alkylating agents and things where you have to worry about potentiation are things that you kind of classically worry about. But that's one where the half-lives of these medications and the kind of the competing mechanisms are really, really infrequent. And as with modern immunotherapy, it's becoming so much more infrequent.
Because they're different than the adriamycins and the bleomycins.
It's really
and
changed.
The cisplatin. Bleomycin, if they were on it, I think you could never get hyperbaric.
That was right. So that was a holdover from animal studies that the risk-benefit conversation was kind of always a point of concern. And that was same with cisplatin and things where you're understandably have to address the theoretic concern and what it would be to the patient. There have been patients that were treated because the severity of their indication was so much that it was, again, a shared decision conversation of I'm willing to incur this risk to potentially have this benefit. And it wound up being, again, just kind of a longer conversation, but it's definitely one where the patient needs to know this medication carries with it this theoretic risk and kind of go into it. But thankfully, those conversations are fewer and
far between because the newer agents are a lot safer. All right, relative contraindications. Obviously, a sinusitis. You don't put somebody whose head's already pounding from, having a sinus infection in a chamber, and then their head would blow off. Not literally, but you know what I mean.
It'll feel like it will.
It feel like it will. They're not going to be very comfortable in the tank or in the
sinus squeeze
multiplace.
is a miserable thing.
We talked about seizure disorders. As long as they have a seizure disorder that's been relatively controlled on medications, they can be still treated, but cautiously. COPD, who are on CO2 retention. These people are on CO2 drive, right?
Yep.
These people breathe because their lungs are so terrible. They breathe the brain is causing them to breathe by their carbon dioxide amount in their bloodstream. So all of a sudden, we put them in a chamber of oxygen, and they stop breathing. So you want to avoid that in CO2 retention, COPDers.
The other thing I'll add for CO2, and this is less applicable to some of the kind of chronic COPD people, but it just from a physiologic concept, is that CO2 causing that vasodilatation, that expansion of those vessels, can offset some of the protection of the constriction. So your oxygen toxicity risk that your body normally tries to account for and diminish, you wind up eating into that buffer a little bit. And that's why you may see otherwise really healthy people, and it's an inducible thing. There are military studies of healthy people where they tried to get them basically to make an excess of CO2 at depth and try and cause that effect.
Interesting.
And that was something where it may be something, if you find someone, their breathing rate, or if they're intubated, their ventilation rate, something to be cognizant of. You don't want to have unaccounted for kind of CO2 where you get then that expansion of the vessel, because now usually those are sicker people, like you said. They're not already dealing with a lot of buffers physiologically anyway, where they have a lot of health to borrow from. That it's just an added thing on the inpatient side.
Got it. And then we have these real tall, skinny guys that come in, and they've had spontaneous pneumothorax because they're all tall and skinny guys. They've had a history of that. I'd be very cautious and maybe say that's a relative contraindication and be very careful in the dive. Those just recently having thoracic surgery for whatever the reason, you don't want to mess the surgeons up. The surgeons work up. And otosclerosis, and that's scarring of your tympanic membrane, so you don't want to. That's probably a weakened area. You don't want to blow that out. And optic neuritis and congenital spirocytosis. I don't want to get into the physiology of that at this point. However, they're just relative contraindications to the use of hyperbaric. Now, my last question. Lesa, how do we increase utilization of this relatively safe and effective modality? Do you have anything to offer in that direction?
I think education.
Okay.
Reminders, awareness.
Are we getting that? Are we educating? I remember that I gave a lecture to the whole staff at Christiana a long time ago, talking about the benefits of hyperbaric and wound care and how we did it. Remember, wound care is we generally treat the wound by debriding it weekly. This gets all the good humors, as we call it, in our bloodstream to the area, growth factors and things to make that wound heal quicker. But hyperbaric can also help in so many ways, and I don't think we're utilizing it in those ways. That one patient, I found out a little bit too late, and I told you his leg almost was turned white, and he lost all blood supply. To speak to the surgeon, the danger is that to transport that individual from the operating intensive care unit at ChristianaCare up to the one in northern Wilmington, to compromise the patient a bit further. It could. So putting him in a chamber there, wouldn't it be nice if we had a multiplace chamber right outside the emergency room at ChristianaCare?
It would be very nice.
Man, they come. That would
geographically warranted.
And it would. I don't know why we don't. I don't know what the expense. What's it cost?
I think it depends on who you buy it from.
Right.
The cheapest one we can buy.
There's still.
It still works well.
The issue is less so. My understanding, having never. Thankful to a lot of patients, I'm sure they're happy. I've never had to build one. But basically, this is something where my understanding is that it's the cost to a hospital or administration is negligible. It's more so the footprint. That's the biggest issue, is a multiplace takes a very large section of space. And the one thing that hospitals understandably have to prioritize above all else is space. So the cost compared to replacing a 2-year-old MRI with a 1-year-old MRI and things like that is negligible. The infrastructure footprint is large because with it is a lot of the construction components, but what the flexibilities of that are scale. So there are smaller options. There are inpatient options. There are ICUs that have monoplaces in them. There are things like that where they have solved this problem a couple different ways, and the question dictates the answer as it should, not the other way around. And unfortunately, and that's why many multiplaces are so different, is that they give them a space and they say, work within the confines of this. And then the clinicians need to say, well, it needs to be able to do this, this, and this. These are our patient populations. These are who we need it to treat. And then you can work, and this is where deck chambers come in. And deck chambers, like you see in commercial dive rigs, you can do full maxed out, which are called table 6s. It's a U.S. Navy table, and it's one of the larger tables as far as duration and depth goes. You can do those in a deck chamber off the side of a boat. You can definitely do it on a hospital campus.
Yeah.
And that's something where there's a middle ground that I feel like that's where, and exactly what you guys are doing with this, which is bringing attention, constantly beating the drum, constantly circling back, is that's where people seeing that there is a middle option, that it's not this huge, giant 2-story chamber or a mono. There are companies out there that will make you any shape, any color, any size, and they'll do it within the box that you carve it.
All right. Everybody, put in some money. We'll build one.
There you go. Yeah.
But I think that maybe, Lesa, you can bring this to the attention of the Christiana staff and say, listen to this and see what we can do if we had a Monoplace chamber. I mean, a Multiplace chamber. I have to say this has been a very interesting conversation for me. I hope it wasn't super technical for those that aren't up on medicine, but it's something that's been dear to my heart for a very long time. But there's anyone who wants more information on hyperbaric oxygen treatment. I'm going to give you Dr. Gaskill, who's going to tell you how you get in touch with his department and ask questions.
Yeah. So my department main number is 215-898-9095. That'll get you through to it's the same inpatient, outpatient Multiplace. There's always someone there to answer during regular hours, and most likely we're there probably evenings. But that's something where that number will give you the best kind of constant way to get a hold of us as far as questions, consults, or even just kind of musings that you guys may have. I'm always happy to talk about this stuff.
Is there a good place for them to go on the internet and look up all about hyperbaric oxygen treatment?
So unfortunately, and this is something that I appreciate you, when you introduced me to it, kind of saving me from a lot of the bad information that's online. There's a lot of mixed information out there, a lot of very selective data reporting or some bad studies just outright. One of the best places that I tell people to go is the UHMS. It's the Undersea and Hyperbaric Medical Society. They are a repository for a lot of clinical studies, a lot of outside data, and they do a lot of education at all different levels. Interesting for students, nurses, docs, anywhere in the bandwagon, but it's really a nice resource, and they have a bunch of different kind of levels of interest to kind of explore.
Great. Lesa, in this area, where can they get in touch with you to learn a little bit more, or even to ask if they can participate in hyperbaric treatment? Go ahead.
Sure. So if they want to look at ChristianaCare online, we do have the portal if you type in wound care. Our main office number is area code 302-320-4050. And we do have 2 locations. So we have the North Wilmington location, and then we also have a Wound and Hyperbaric Medicine Center in Cecil County at Union Hospital.
Very good. And again, I offered this early in the discussion, but anybody interested, or if this has piqued your interest in the medical field, Hyperbaric Medicine Practice by Eric Kindwall and Harry Whalen is a great book to talk to you about hyperbaric oxygen, how it works, what it does, and hopefully you'll understand it a bit better. And maybe we'll someday have a bigger center in Delaware so we could treat many other things that we need to treat. Thank you. Thank you, Lesa. Thank you, Zach.
Thank you, Alice.
Thank you.
This is Nick Biasotto saying thanks for listening, and this is the Medical Society's podcast, Delaware Healthcare Reality. There'll be more coming, so stay tuned.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. Delaware Healthcare Reality is produced by Tom Mitten. I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the hosts or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.